Good evening, everyone. First of all, I'd like to thank the organizers for this event for the invitation to come speak to you today about changing the conversation in NMOSD. I would like to thank our sponsors for sponsoring this event. And then finally, I would like to thank the audience because without your support, these meetings could never happen. I'm Ahmed Shatila. I'm a neurology consultant at Sheikh Shakhbut Medical City. And today I'm going to talk about changing the conversation in NMOSD, which is sponsored by Roche. Here are my disclosures. So NMO, there we go, just minimize this. NMOSD is a rare, progressively debilitating autoimmune neuroinflammatory condition. The hallmarks of the disease are motor disability, which encompasses paresthesias and mild to severe paralysis, depending on where the lesions are located in the spinal cord. Fatigue is a common symptom of the disease. I currently have around 5 patients with NMO/NMOSD who follow with me at SSMC, and all of them complain of pain, which seems to be a hallmark of the disease. Bladder and bowel dysfunction is not uncommon, given the fact that this is a disease that predominantly affects the spinal cord, so it's not uncommon to see bladder and bowel dysfunction. Nausea, vomiting, and hiccups is actually part of the diagnostic criteria, and this is most likely because the disease tends to affect the area postrema regions or the chemoreceptors in the brainstem, and it's not uncommon for people with an NMO to have nausea, vomiting, or hiccups. And finally, visual impairment, because again, this is a disorder that predominantly affects the optic nerve and the spinal cord. When we look at NMOSD, the hallmark of the disease or way the disease categorizes or manifests itself is that you have relapses. Most commonly, you have relapses. And during the course of the relapses, you'll have a significant accumulation of disability. And then you have a period in between relapses where the patients may be stable until the next relapse. And why is this important? Because although the patients are stable in between relapses, the relapses itself can be extremely disabling, and I'll be talking about one of my patients today. And untreated, half of the patients with NMO will require the use of a wheelchair or will become functionally blind within 5 years of diagnosis. And 40% of the patients with NMOSD are initially misdiagnosed as MS, given the fact that the disorder first of all, affects the optic nerve and the spinal cord, and the lesions look like MS lesions, but with careful attention, you'll notice that they're not the same lesions, and it's not the same disease. The prevalence is wide. So it's anywhere from 0.05 to 13 per 100,000 people, and the age of onset is in the mid-30s. Next slide. So NMOSD has a clinical and radiographically features that are distinct from MS. So NMOSD is not just optical spinal MS or MS of the eyes and spinal cord. They're two different disorders, and the patients that are affected are not the same, and the presentation of the disorder are not exactly similar to MS. So when we look at MS, it's predominantly a younger person's disease with the median age of onset of 29. With NMOSD, it tends to affect people that are somewhat older with the median age of 39. With MS, we know that the lesions are throughout the entire CNS, but while in NMO, it's in the optic nerve and in the spinal cord predominantly. But we do now know that you can see lesions in the brain with NMO and NMOSD. The spinal cord lesions in MS, they tend to be shorter segments, but with NMO, the diagnostic criteria, actually, you'll have long, longitudinally extensive lesions more than 3 vertebral segments, which is actually part of the diagnostic criteria. Now, while there's no specific biomarker for MS, there is a biomarker for NMO, which is the AQP4 IgG positive. AQP4 IgG, which is an antibody to the aquaporin 4, which is in the astrocyte foot process of the brain. And usually it's positive in 75% of people with NMO. The disease course with MS, as we know, 85% of people will have a relapsing remitting component. And with NMO, it's the same thing. It tends to be around 80 to 90%. How about the severity of the attacks? With MS, we know that the attacks can be individual. Some attacks may be mild, but while NMO, you may not have as many attacks as in MS, but the relapses in and of themselves can be extremely severe and extremely disabling. And with MS, we know the relapses and the disability are relapse independent. With NMO, they tend to occur more commonly with relapses, meaning that there is a period in time with NMO patients where if they're not having relapses, they may appear to be stable, but that doesn't mean that the disease is stable. Are there any autoimmune conditions that coexist with NMO? They do. Sometimes you may see double-stranded DNA. ANA can sometimes be positive with NMO patients, but with MS, it's rare. Now, why is it important to diagnose this disorder? Because, as I've said, NMO is not just MS of the spinal cord and optic nerve. It is a different disorder. And why is this important? Because traditionally, the medications that we use to treat MS can actually be ineffective, or it can actually be harmful for patients who, if they are found to have NMO. Some examples would be the beta interferons, which is the mainstay and which is the first line treatment for MS patients. For NMO patients, these treatments are ineffective at preventing relapses. There have been reported exacerbations of relapses within a short time of treatment. It may actually increase the relapse rate of NMO patients, and there is a higher risk of new clinical manifestations than with other immunosuppressive treatments. And it does increase your aquaporin for antibodies. Natalizumab, highly effective treatment for MS, not very effective for NMO. It has failed to show any disease control in patients with NMO. The relapse activity appears to be unchanged, and there is a severe disease exacerbation which occurs during and shortly thereafter treatment with the medication. And fingolimod, which is a sphingosine 1-phosphate receptor, it is not effective in treating NMO patients, and actually case reports have shown development of bilateral extensive brain lesions 2 weeks after administration. So while these three medications, highly effective in MS patients, not very effective for patients who have NMO or NMOSD. In the UAE, there are a number of unmet needs across the NMO care pathway which need to be addressed for successful management. And I'm going to talk a little bit about this right now. First of all, we need proper awareness in epidemiological studies. There's a low awareness among healthcare providers and the medical community about NMO. There's low awareness among patients that they actually have NMO. A lot of times, again, it's a rare disorder, so a lot of times these patients are lumped together with the MS care groups, or they're thought to have MS. There's a low awareness among the community and population, as I just mentioned, and there's absence of any registries or information on patient numbers that actually give us adequate amount of how many people in the country have NMO. And why is this important? Because if we don't know how many patients we have in this country with NMO, we're less likely to develop good treatment guidelines or good pathways to help better care for these patients. Healthcare providers, they need education and training on screening and referrals, so that if a healthcare provider is suspecting NMO, he or she is able to send these patients to a neurologist so that they can be better addressed and better diagnosed. Sometimes now, this is not as common, and at least at SSMC, but our delay in appointments, especially if you live more in some of the more isolated areas of the country, it may be hard to see a neurologist, or it may be hard to make an appointment with a neurologist within a short period of time for proper diagnosis. In regards to testing, education needs to be done for neurologists as well as healthcare providers about the training on how to diagnose this disorder appropriately, because as I mentioned, this is not MS, this is a distinct, entirely different entity and different disease. So the reason why that's important is because treatment's different. Ophthalmologists need to be properly educated, and optometrists in order as well, if they suspect NMO, they can at least start the referral pathway so that these patients can see a neurologist. And we need local lab and quicker turnaround in regards to blood testing and MRIs in order to determine if there's any lesions in the spinal cord or an optic nerve, which are more common in NMO patients, period. And finally, treatment and follow-up. We don't have established treatments for these diseases. Now, that has changed because now we do have some medications that are FDA and EMA approved that have been shown to be effective in treating NMO patients. And this is important because now that we have medications for these patients, we can actually potentially change the pathway or the disability pathway of this disorder. We need patient initiatives and patient support programs in order to help group them together so that we can follow these patients effectively and help monitor them and prevent future accumulation of disability. And we need support groups and rehabilitation programs for patients with NMO and NMOSD. So I'm going to talk a little bit about a patient of mine from who I'm currently following. So she's a 65-year-old female who developed painful visual loss in 2015 while she was in Syria. Now, at the time, due to the civil war in Syria, she never followed up in Syria, and then she came to the UAE, and she kind of thought her vision was improved, so she didn't really think much about it. She never went back to normal in her vision, but she thought, oh, she didn't really think much about it, unfortunately. And this was until 2016 when she was admitted to Mufraq Hospital with acute weakness in bilateral lower extremities and urinary retention. And when an MRI was performed, she had on exam, she also had a sensory level at T4. Now, an MRI was performed which showed a longitudinally extensive lesion from T2 to T6. At the time she was given Solumedrol, there was some mild improvement in her symptoms, but nothing significant, and then we proceeded with 5 cycles of plasma exchange. Again, improved a little bit. She went from 0 out of 5 movement in her lower extremities to 1 to 2 out of 5. So still severely disabled. AQP4 was positive, and she was diagnosed as NMO. At the time, we have started her on rituximab, and she's since been stable, but she's still confined to a wheelchair. So while her disease has been stable, she's only really had 2 relapses, one in her eyes, in her optic nerve, and then the devastating relapse in her spinal cord that has now left this patient confined to a wheelchair. So again, like I said, even though with MS, you don't see this level of disability accumulation this fast, not always, but with NMO, it can be pretty devastating. And that's why it's so important to diagnose these patients earlier, because treatment could make a difference in their overall outcome. A need remains for early, accurate identification of NMOSD and proven effective treatments to prevent relapses and to improve symptoms need to be developed. So first of all, what do we need? We need better knowledge. We need to improve the understanding of the disease to enhance patient outcomes. Like I mentioned with my patient that I previously spoke about. We don't know, but had she been diagnosed earlier, maybe the second relapse wouldn't have been devastated or could have been prevented altogether. We need to support optimal management of the disease with evidence-based medicine. We need proper diagnosis. We need to improve the diagnostic procedures, make sure that the testing available for the AQP4 antibody is easily available and is accurate so that we can diagnose patients with NMO. We need wider symptom control. We need to reduce the need for treatments and manage the wider symptoms that is common with patients with NMO in order to improve their quality of life, such as reducing pain, improving fatigue, and overall reducing the burden or improving the quality of their life. And finally, we need maintenance treatment. We need to develop treatments that are consistently and effective at preventing relapses, like I said, and to improve the quality of life and maintain low levels of disability for these patients so that they can become, so that they continue to remain productive members of society. Now, there is limited evidence for the relative risks and benefits for current treatments in NMOSD. We need treatment guidelines, and we need to acknowledge the lack of level 1 or level 2 evidence. We need recommendations are mostly based on small case series or case reports or retrospective analysis. And systemic immunosuppressive and chemotherapeutic agents are prescribed off-label, such as rituximab. We don't have large-scale trials, but these are based, as I said, small case series, retrospective, but these are not double-blinded, placebo-controlled trials. And yes, it helps, but we need better trials, we need better treatments. And until recently, no drugs or treatments have been proven to be well tolerated and effective in NMOSD management. So doing now what patients need next. And with that, I will end my presentation. I would like to thank everybody for attending today's symposium sponsored by Roche. Unfortunately, I will not be able to give this presentation live as much as I would have loved to have been there in person. I hope you enjoyed this presentation and looking forward to any questions and comments. Thank you very much.